turn now to our first presenter. Dr. Jennifer Havens is professor at the University of Kentucky College of Medicine and is an epidemiologist with an appointment in the University of Kentucky's Center on Drug and Alcohol Research. Dr. Havens' primary research interests include the epidemiology of the prescription opioid use issues in rural Appalachia, the comorbidity of substance and mental disorders, and HIV and other infections complicating drug use. In addition to serving as principal investigator on the large-scale NIDA NCI-funded hepatitis C treatment study in Perry County, Kentucky, which is the topic of her presentation today, Dr. Havens is also principal investigator in an ongoing NIDA-supported grant called The Effect of Structural Interventions on Substance Use and HIV/HCV Risk Among Rural People Who Use Drugs. Please join me in welcoming Dr. Havens, who will be presenting to us on the Kentucky Viral Hepatitis Treatment Study, or KEY-TREAT, KY Treats.
Thank you. Let's see if hopefully we can get this pulled up. Let's see, share. Can you all see that?
Yes.
Fantastic. That's a win already. So thank you all so much for hosting this webinar, and a particular thanks to Drs. Ward and Compton and Lindsay Hebert, who were instrumental in inviting and then making this so easy for me to be able to present this very exciting study to you all today, the Kentucky Viral Hepatitis Treatment Study, or KEY-TREAT. Oh, come on, now it doesn't want to move. Move. Okay, let's start over. There we go. So can you all still see that?
Yes.
Okay, excellent. So the overall goal of KEY-TREAT is to eliminate the transmission of the hepatitis C virus in Perry County, which is a small county in eastern Kentucky, by drastically reducing the community viral load. So in essence, a micro-elimination study. And this is our clinic. It's in Hazard, which is the county seat of Perry County, Kentucky, and it's within the Appalachian Regional Health Medical Mall. So we are a nurse-led model, and as you've heard already from several of the folks that have spoken, what we're looking to do is have a model program that can be implemented around the country or potentially around the world. And in this case, we're focused really on rural areas. So we wanted to make it such that some of the results from this study would potentially be able to be translated to other areas who are facing similar issues with hepatitis as a result of opioid use, continued opioid use and injection. So we're trying to have a very streamlined protocol, and going through our visit schedule, we have a baseline visit. It's day 0 to establish our eligibility. They have to be a Perry County resident, and that's because, as Dr. Compton mentioned, we did have a donation for our drug, so we have a limited supply of drug. Detectable viral RNA, and they have to be at least 18 years of age, and that, again, is due to the drug and the FDA approval. So we do point of care testing, anti-HCV, so antibody testing for HCV and HIV, and we are fortunate to have access to the Gene Expert, the Cepheid platform, to conduct viral RNA testing, which will give us RNA results within about 45 minutes. We do a medication reconciliation, and medication is initiated on day 0 for eligible participants. So those folks, anybody hearing that? Okay. And medication is initiated on day 0 for those participants who have viral RNA. So we'd like to have them come back at 2 weeks to see how everybody's doing. And we expect to see if they've been using the medication as directed. We expect to see declines in their RNA because the Gene Expert is a quantitative test. We should be able to see significant reductions in their viral RNA. So if they're not doing well at 2 weeks, we try to intervene wherever we can, talk it through with our social worker and say, what's going on? Is there anything we can do to help you to be more likely to use the medication? If there's something going on in their life we can potentially intervene on, we try to do that. If they are doing well, we will send them home with 6 to 8 weeks of medication, have them come back at 12 weeks. The nice thing is we have some flexibility there. So folks that aren't doing so well, we can see them every couple of weeks. And those who are, we can have them come back at 12 weeks and then come back for their SVR visit. And that's really what, in terms of a treatment protocol, that's where it could potentially end. Obviously, we'd want to see them clinically after that as well. But what we're doing from a research standpoint is hoping to expand the data and the literature on reinfection and seeing them at 6 months and 1 year post-treatment completion. So really we have them for about 18 months and we can really look at some of those long-term outcomes, which we don't have fantastic data yet. There have been some wonderful studies throughout the world, but the data often don't go beyond several months out. And so we're trying to rectify that and get as much post-treatment SVR data as we can. So as I mentioned, we were fortunate to receive a drug donation from Gilead. So Sofvel, 1 pill per day for 12 weeks. As you all probably know, very favorable side effect profile. Nausea and headache is most commonly reported. And that's another reason we'd like to bring folks back at 2 weeks. If they're having some issues with any side effects, we can potentially work with our nurse practitioner, will work with them to see if there's another time of day or if they could take it with a meal and work through any of those issues so that they are, again, motivated to continue with the medication. We do have daily text reminders, which are incentivized at $1 per day if they respond with a yes, a no, an emoji, have a nice day, whatever. If they respond to us, we know that they received the reminder and we will give them $1 a day. And that's worked really well thus far. And many of our participants also have this medication device, which is on the right. And it's the Take as Directed, or TAD, developed by Intent Solutions, really with the purpose of dispensing scheduled drugs. That box in the middle is actually a fingerprint scanner, and all the way to the right, it's almost like a gumball machine. It delivers the pill. And it's about a 20, since it's 1 pill per day, and we have set the time with each participant to which they'll take it. So we have about a 24-hour window for which it will open. And the interesting thing is we've been able to look at the daily text reminders, the responses to the text reminders, and then see when they actually take their pill. And we see that they're very highly correlated, which is wonderful. And then if we have folks who have reactivation or recurrent reinfections, we do have Vosevi, which is soft Velvox, at our disposal, but we have not used it as of yet. So just in terms of what we do for labs, obviously I mentioned we do rapid testing for antibodies, HCV, HIV, and we do have the rapid quantitative testing for HCV viral RNA at our disposal as well. Given that it's not FDA approved, Sofvel, for use in pregnant women, although we've seen a couple of fantastic results coming from some studies, we do urine pregnancy screening for all women of childbearing age. And we have removed one woman from active medication. She was pregnant at the 2-week visit, and she has since come back and restarted after she gave birth. And then we do a blood draw, and really the things that we're interested in from that are the HCV genotype in the fibrosis stage, which we're able to get from our LabCorp testing. And when we were talking through what this study was going to look like, especially, Drs. Ward and Compton, and we really were thinking about a sort of holistic approach to how we were going to be offering HCV treatment in a small community, making sure that the availability of treatment for opioid use disorder was there. And at one point in time, we thought we were going to provide it as well, but there's a lot involved with that. And that was perhaps going to even take more time to set up than the treatment program. So we've contracted actually now with 2 providers. And anyone who's interested in treatment, we will subsidize the treatment for them. We're doing hepatitis A and hepatitis B vaccinations. So we're kind of billing ourselves as kind of one-stop hepatitis shopping. We also are involved with the syringe program in Perry County, because if we're thinking in terms of how do we prevent reinfection, obviously if they're continuing to inject, then we would really encourage them to use the syringe program throughout their treatment and obviously post-treatment, especially if they achieve SVR. I mentioned our social worker, who has been really instrumental in establishing a referral network for all different services that are available in the community, which in some of these small communities, there is not a lot of availability. So she's had to get fairly creative in some instances. And then Kentucky is fantastic in that we're really kind of an all-in Medicaid state, Medicaid expansion, but we still have folks who are not enrolled. So she's helping them get enrolled in Medicaid as well. And then there's no Lyft, no Uber. Taxis aren't fantastic, but there is a medical transportation service that we've been able to contract with to go pick people up at their homes if necessary and bring them to us. Or if they need to go to the university to see our infectious disease physician that we contract with, then they can do so. We've only had, I think, 2 or 3 participants go up who had, they were cirrhotic. She really wanted to see them in person and establish that kind of long-term follow-up with them. But for the most part, we've been able to treat everybody in-house at our clinic in Hazard. So what are the primary outcomes? Medication initiation, and with that goes recruitment, screening, enrollments. How do we get folks to the point where they are enrolling in the study and they're actually initiating medication? How many people are we able to get through that 12 weeks of soft-vel? Obviously SVR, so cures and reinfection are huge outcomes in this case. And we also are able to do a comparison to Pike County, which is our control county. And I believe our epidemiologist that is building that data set is on this call right now. So we will hopefully be able to start to look at the incidence, kind of the historic incidence and prevalence pre and post in both our intervention Perry County and our control county, which is Pike County. So what we're looking at here is the green bars are the people who have called, the number of people who have called by month. So we started in September of 2019. And I do want to note that basically we were in for 5.5 months and then COVID hit. So everywhere from March 20 on is COVID times. So we really had 5.5 months to hit the ground running. You can see in January and February of 20, we were going gangbusters, and then COVID hit. So I will talk a little bit about throughout the presentation about the impacts of COVID, but what we're seeing here is we've screened on the phone almost 500 folks. But only about 400 have come to do the in-person screening. So these are eligible folks in the green bars, and then those who actually showed up to do the in-person screening, which is obviously required to start the medication. We need to know if they have viral RNA. So we're losing about 20% from the call to the in-person visit, even if it's within 2 days. We try to get them in within 2 days of calling. So they could potentially go from calling us at 2 p.m. on Monday, Wednesday at 10 a.m. they could be on the medication, started the medication. So we know that there's a lot, that the motivation, especially in this population, waxes and wanes. And we try to get them when they're still in that mode where wanting to help themselves and really wanting to do something for their health. So we're looking at some of the factors and some of the little bit of data we have about them from the phone screening and trying to figure out who they are, why they're not coming in, and obviously attempting to intervene to get them in. So about half female who are calling, you'll see 38 years of age, and I'm sure Dr. Ward will attest to even 5 years ago, the average age of someone being treated for hepatitis C was significantly, almost double that. So at least 60s, 70s. So we're really starting to see, this is the population we are hoping to reach. All but 4 folks that have called in had a history of substance use. About 40% are currently using, and about a little over half of those are injecting. And we've seen a huge shift from opioids to methamphetamine, which I know is happening in opioid using populations nationwide. This is not something that's unique. But what I think at the end of the day we'll have is data on whether you can get someone through 12 weeks of medication if they're actively injecting methamphetamine. And so far the answer is yes, you can. So this is looking at the total this is from the people who have called in and to enrollment. So 47% of the people who are calling in were actually able to enroll. And I already talked about the 20% that just aren't showing up to their intake appointment. The other 30% are either don't have antibodies or viral RNA for hepatitis C. So they're not eligible, obviously, for treatment. So basically half the people that call were able to get enrolled in this study. Those who are enrolled slightly less than for females, and the median age goes up just a little bit, consistent with the population of Appalachian Kentucky, about 96.6% white. And we haven't had a whole lot of uptake on the offer for the subsidized treatment. And that's because almost half of the folks who enroll are actually already in a program, a medication for opioid use disorder treatment program, which is fantastic. And as I mentioned, Kentucky's Medicaid is very inclusive, and we've had a huge uptick in the number of people enrolled as a result of the Medicaid expansion in Kentucky. And it looks like it's working, you know, and being folks who look at treatment for substance use disorder, this is very encouraging. This was one of the hallmarks of Medicaid expansion is, can we get folks enrolled in substance use disorder treatment? So looking at the clinical characteristics, and I believe Dr. Ward mentioned this already. So if we were looking at the Medicaid requirements, and Dr. Volkoff mentioned this as well, it's people who were ill. So people who have F3, F4, fibrosis, that is not who we're seeing in this study. The vast majority have no liver damage thus far. So we would, if we had the Medicaid restrictions in place, which many of the states still do, you're not reaching this population, but this is a population that is potentially continuing to transmit the virus. So if we're thinking about eliminating hepatitis, these are the folks we need to be treating. So we are getting to this population, which I think is very encouraging. So in terms of medication initiation, 90% started on day 0. So if we had someone, oftentimes we'll have people who walk in who don't call, who just, they've heard from a friend about this program and they come in, they could potentially within 2 hours take their first dose. So walking in the front door and have their first dose within 2 hours. We do those medication reconciliations. So if there's potentially a medication interaction, we ask that they go to their primary care provider and change the medication, so primarily statins and PPIs, and we get a letter from the provider saying that that medication change was conducted. The other folks we don't start on day 1 are those who have a known hepatitis B infection. We also do hepatitis B testing as part of our lab work, so we can identify that as well if they're not aware of it. So we had one active HBV case who we offered to co-treat both their HBV and HCV, since we do have an infectious disease doc on with us from the university, and they declined. We also had our third patient that came in. We said, oh, everyone's going to be, you know, F0. Well, she was cirrhotic. So we had a challenging patient, our third person that walked in the door, and she declined treatment, and which was, I think, a little bit disheartening, but we've had a lot of success since. And then we have 5 folks who requested medication changes. We requested medication changes before we could start them, and they never came back. So in terms of getting folks through the 12 weeks of medication, about 3/4 have made it through all 12 weeks. Thinking about some of the things that we're looking at, obviously one of the things we're interested in, who are the people that don't make it through? So we've had 2 deaths prior to 12 weeks. Both of those, unfortunately, were overdoses. We've had 7 deaths total, all unrelated to the medication. We had, again, that one pregnancy I mentioned, and then 47 lost to follow-up. We had a homeless shelter that actually ultimately shut down. We had quite a few folks come in from there. They were very hard to keep track of, and we ultimately lost track of some of those folks. We have a great agreement with our local jail where if they are incarcerated, we're able to bring the treatment up, and they are fantastic about administering the medication. In fact, our folks do really, really well that are incarcerated doing the treatment, because we know they're getting their pills every day. And then if they've gone into residential treatment, either for mental health or substance use disorder, oftentimes we aren't able to get the meds to them, but we will make every effort to do so. We've driven across the state to deliver the medication to folks if they call and request it. So SVR, this is the big one, right? We want to get people through the trial. We want to get them cured. So we're sitting at about 94.4%. We were at 100% before COVID. And as Dr. Volkoff mentioned, we've seen a lot of adverse effects of COVID on folks in terms of relapse, and that's what we have. All of these folks had relapsed at some point and began injecting again. and began sharing. And we see that they're new infections, the majority are new infections, because we do genotyping. We can see it's a different genotype. So reinfection is also something we're looking at long-term. And so far, 3 of the 76 people, actually 2 of the 76 that we've seen at our 6-month visit were reinfected, and 1 came back at 4 months. He hadn't made it to a 6-month because he was tested as part of his buprenorphine treatment program and was found to be reinfected. So he came back to us early. All the folks that have either not achieved SVR or have been reinfected have attempted to start again. Not all of them have been successful, but they've all been motivated to restart. And we've been accommodating with that, and we've restarted everyone who has requested to restart. So finally, I'm going to go over the impacts of COVID and then some conclusions, and then I'm happy to answer some questions. So the university, since we are a research study, we're under the Vice President for Research. We were asked to cease as many of the activities as possible during at least those first 3 months. So March, April, May, and then some of June. So it was about 3 months. But understanding obviously that there were people in active medication trials, ours being one of them. So we were able to still deliver medication to people at their homes if they could come into the clinic, so we could do our RNA testing, our urine pregnancy screening. We had smaller clinical teams, and of course, following all sorts of COVID protocols and symptom screening for our participants. So recruitment was halted for those 3 months, and as well as from Thanksgiving through New Year's, there was the rates were very high in Perry County. We were having a hard time getting people to come in, and it just made sense to go back to the protocol that we had established when we couldn't recruit. So we were having small clinical teams delivering or doing in-person visits when necessary, but really trying to limit. We limited all recruitment, didn't do any recruitment, but just were able to provide the care that they needed for the folks who were already enrolled. All of our community screening activities have been canceled. So we had 5 events on the books, and we weren't able to do any of them. That's going to end up being one of our major recruitment tools. So once those get back going again, I think we'll see an uptick in recruitment. Every time we've come back from a phase where we weren't able to do recruitment, it's been really slow getting back up and running. So it would take about 6 weeks for the folks to really start to get going, even those who we were trying to reschedule for when they were, when we had to cancel their appointment during the pandemic. So I think it's like this for everybody. I don't think this is certainly unique at all. We have had several reinfections, again, due to relapse during the COVID, and then 2 overdoses that were fairly recent as well. So thus far, in the 220 folks we've enrolled to date, I think we've done a pretty good job in a population that can be challenging in recruiting, treating, and curing these rural residents. Excellent SVR rates, thus far low reinfection rates. We hope to keep it that way. We've had 21 restarts after those lost to follow-up. We'll have people just show up out of nowhere and say, hey, I'd like to start again, even though we've considered them lost to follow-up. Recruitment has slowed a little bit, so we've really tried to get some of those activities, those community-based activities going again, and regular recruitment days at the syringe program. And one thing that's I think has been fantastic. So additional providers in the area have actually started to treat HCV as the Medicaid restrictions have been either removed altogether or significantly lessened. And that's good. If we circle back to the original goal of Key Treat, which is to eliminate hepatitis from the community, the more people that are treating hepatitis in the community, the more likely we are to meet that goal. I think what Key Treat has done is demonstrated that everyone can and should be treated. And I think that the local providers have been encouraged by what they've seen us do and have begun to engage that population when previously they would not. So I need to acknowledge certainly NIH and NIDA for really spearheading this. Dr. Ward, when he was at CDC, was also fantastic. And really this collaboration between NIDA and NCI and Doug Lowy, who really took an interest when he visited and when Dr. Volkov visited, and they went back and talked about it and asked us to put this together. Gilead's been a fantastic partner. Really, they just want to know what's going on. They send us drug when we need it, and they like to get some updates because I think they're really interested in how this is going. And our team, I mentioned before we came on as a big group, have just absolutely responded in a fantastic way to these circumstances in the last month, and have really put those participants first and made sure they got what they needed, even though they weren't necessarily in a good place. So I couldn't be more pleased with the way that the study is going, especially given the past 12 months, and hope that we can continue to do some good in some of the rural areas that have been adversely impacted by the opioid epidemic. Thank you.
Thank you very much, Dr. Havens, for leading us off today with a really wonderful update about your elimination trial in rural Kentucky. While Dr. Irvin is getting her slides up, there are quite a few questions in the chat for you, Dr. Havens. I'll just relay a couple of them. But one of them that's very interesting is, can you explain how you identify the individuals that you attempted to reach by phone? So how'd you get all those phone contacts? Do they call you or do you call them?
Well, it's a combination of both. So we did our PR department at the University of Kentucky is fantastic. So we did a kind of a kickoff blitz, if you will, and that was picked up by the local media. And it was on it was WYMT Facebook page. Facebook is huge in Eastern Kentucky. So the Facebook page, they put the story on that. We got a lot of hits from that. And of course, small communities. So once a few people enrolled and said, hey, they're okay, word spread through the networks. So we knew that that would likely happen. But we also, the study that you mentioned, that we're also conducting, we've been doing since 2008, that study provided the data that was the impetus for KeyTreat. So we knew there were a lot of hepatitis C positive folks in that study. So when they signed the consent form, they agreed to be contacted for future studies. So we also already had kind of a built-in recruitment group, if you will, and we've been able to treat quite a few of the folks from that study as well.
Well,